Hello and welcome to our channel, where we discuss common medical topics from a practical point of view. Today's discussion is about hypertension, a very common topic that medical personnel still have confusion over. This video will provide a brief overview of hypertension, and we will deal with in-depth topics later on. So just a small disclaimer before we begin this video. This video is for educational purposes only. Medical personnel are required to make treatment decisions on the basis of local protocols and institutional guidelines. So briefly discussing our agenda, what we'll be doing is discussing the definition of hypertension, a brief overview of its pathogenesis, its diagnosis, which is very important, I think. Diagnosis in a patient who first time presents with hypertension, its evaluation and management. Let's go over briefly the definition of hypertension. The definition that we will be using is the AHA or ACC definition based on appropriate blood pressure measurement. We will be discussing in another video what exactly appropriate blood pressure measurement means. So stay tuned for that video. So normally the classification, in the recent years, what has happened is the thresholds or the cutoff thresholds for diagnosis of hypertension have been lowered. This is because it was seen during the various trials and meta-analyses that lower blood pressure is associated with reduction of cardiovascular events. So the normal blood pressure now is appropriate blood pressure, systolic blood pressure less than 120, and a diastolic blood pressure of less than 80 millimeters of mercury. This again is based on appropriate measurement of blood pressure. So another threshold, the elevated blood pressure. When do you say someone has elevated blood pressure? If his systolic is between 120 and 129, and diastolic blood pressure is still less than 80 millimeters of mercury. If someone has a reading between in these thresholds, then you can say that the patient has elevated blood pressure. So stage 1 hypertension. A person who has systolic blood pressure of 130 to 139 or a diastolic blood pressure of 80 to 89 is said to have stage 1 hypertension. And a person finally who has a blood pressure of more than 140 millimeters of mercury systolic and more than or equal to 90 millimeters diastolic is said to have stage 2 hypertension. An important caveat in this is that you will always use the blood pressure which is higher. For example, if someone has a systolic of 135 and a diastolic of 95, he will be classified as having stage 2 hypertension rather than stage 1 hypertension. Another caveat, let's say someone has a blood pressure of 125 and his diastolic is 85. He will be characterized as having stage 1 hypertension rather than just having elevated blood pressure. Some other definitions. Let's say someone has a systolic blood pressure more than 130 and a diastolic less than 80. He's said to have isolated systolic hypertension. Someone who has a diastolic more than 80 and a systolic of less than 130 is characterized to have diastolic hypertension. Someone with a blood pressure more than 130 over 80 is said to have mixed hypertension. People who have been diagnosed as hypertensives, regardless of their blood pressure reading, are characterized or defined to have treated hypertension rather than a particular stage. For example, if ambulatory blood pressure or home blood pressure measurements are taken to diagnose hypertension, the thresholds are different. So let's say you use the ambulatory blood pressure monitoring, which takes several readings over 24 hours. Then the mean value changes. So then a systolic more than 125 or a diastolic more than 75 is characterized as hypertension, or a daytime mean of more than 130 over 80, or a nighttime mean of more than 110 over 65. So these definitions are based on if you use the ambulatory blood pressure measurement values rather than the office-based or appropriate blood pressure measurement values. Some other definitions. White coat hypertension. This is hypertension that is seen in clinical settings but not seen out of the hospital settings. For example, if a patient has elevated blood pressure but does not meet diagnostic criteria, then using out of office measurements. And then there's masked hypertension, which is opposite of this. So blood pressure is elevated out of the office, but still does not meet criteria of hypertension when office-based measurements are used. Some points about the pathogenesis. Essentially, the diagnosis or the underlying etiology is not known. Some of the factors include like advancing age, obesity, family history, race. Blacks, unfortunately, have more severe hypertension, which occurs in earlier in life and is associated with more damage or uh, target organ damage than in other races. High sodium intake is associated with hypertension, excess alcohol, sedentary lifestyle, decreased sleep, noise pollution. These are some of the factors that can contribute to the etiology of primary or essential hypertension. For secondary hypertension, several drugs can be implicated, like oral contraceptive pills, NSAIDs, steroids, chemotherapeutic agents like uh, cyclosporine, antipsychotics. Other endocrinological causes also, like aldosteronism, pheochromocytoma, Cushing's, hyper and hypothyroidism, both can be associated with secondary hypertension. Several other factors like coarctation of aorta or renovascular causes of secondary hypertension are well known. So the most important slide, making a diagnosis. So let's start that a patient enters into the clinic for the first time and has elevated blood pressure. Let's see how we go about it. So this blood pressure readings are based on appropriate blood pressure readings, which we'll be discussing in another video, how to take the blood pressure appropriately. So let's begin. So a patient, let's say he has come to the OPD. His blood pressure is more than 130 over 80. So can you label this patient as a hypertension? Let's see later on. So if a patient has an elevated blood pressure, you have to see whether the blood pressure is very, very high. Let's say, is it more than 180 over 120? So if it is, then yes, your job is done. You can label the patient as having hypertension. So a single value of very high blood pressure reading, like more than 180 over 120, is enough to diagnose the patient as having hypertension. Now, you don't leave the patient as such, you treat it whether it's hypertensive emergencies or urgency. But yes, you can diagnose the patient as having hypertension. Let's say if the blood pressure is not very high, it's less than 180 over 120 millimeters of mercury. Then can you label the person as hypertension based on one reading? No, you can't. You need further assessment. So we'll be moving on to another patient or the same patient. Let's say this patient had a blood pressure reading which is elevated, more than 130 over 80, but it is not very high to be characterized as hypertensive urgency or emergency. So how do we go about diagnosis in that patient? So the blood pressure is less than 180 over 120. So what do? You check for what the reading level is. Is it still pretty high, like more than 160 over 100? This will be characterized as stage 2 hypertension. If the blood pressure is high, that means more than 160 over 100, you look for or screen for target organ damage. So what is the target organ damage? You check for the development of hypertensive retinopathy. You check whether the patient has evidence of left ventricular hypertrophy, whether the patient has evidence of renal involvement, whether the patient has proteinuria. If the patient has target organ damage and his blood pressure is more than 160 over 100, then yes, you can label the patient as hypertension or patient having hypertension. So this is based on single reading plus the evidence of target organ or end organ damage. Let's say if the patient has elevated blood pressure, but it's less than 160 over 100. Or if you screen for end organ damage and there's no end organ damage. So let's say the patient has a blood pressure of 150/85, or the patient has blood pressure of more than 160 over 100, but no end organ damage. So this patient, can you label the patient as hypertension? No, you cannot label. You need further assessment. You need to offer the patient home blood pressure measurement. So let's move on with that patient whom we offered home blood pressure measurement. So you take the average of multiple readings. The patient can use the automated device at home, and then you can use the average of that readings. If the average of home blood pressure measurement readings is more than 130 over 80, you can diagnose hypertension. However, if the measurement of the home blood pressure reading is less than 130 over 80, so there's a possible chance that the patient has white coat hypertension since the patient had elevated readings during the office measurement. So let's say the patient is not able to perform home blood pressure readings for some reason. He has elevated blood pressure readings in the office, but no evidence of target organ damage. But the blood pressure is not very high, like more than 180 over 120. So how do you proceed in that case? So if a patient has elevated blood pressure reading and is not able to take home blood pressure measurement for some reason, or the home blood pressure measurement is normal and there's a suggestive diagnosis of white coat hypertension, then how do you proceed? You can offer the patient ambulatory blood pressure measurement. This is a specific device, special device, which automatically records blood pressure during the day and night. So if the ambulatory blood pressure measurement is more than 130 over 80, then you can label the patient as having hypertension. In the other case, if you offer the patient home blood pressure measurement and it's less than 130 over 80, then you can diagnose white coat hypertension. Let's say for some reason, the patient is not able to perform even home ambulatory blood pressure measurement, or ambulatory blood pressure measurement is not available. Now, this patient has presented to the office. He has high blood pressure, but not in the range of hypertensive emergencies or urgencies. His blood pressure is elevated, but there's no evidence of end organ damage. He cannot perform home blood pressure measurement or ambulatory blood pressure measurement. How do you diagnose hypertension in that case? In that case, you have to take repeated office measurements. That means repeated measurements at least 3 times over weeks to months. So if the average value of those repeated measurements, which are done in the office, is more than 130 over 80, then you can diagnose hypertension. If it is less than 130 over 80, then you can exclude the diagnosis of hypertension. I hope it's clear. Moving on to the evaluation. So a patient who has been diagnosed as hypertension should be offered all of these evaluation steps. So you should take a detailed history. You should perform examination, especially looking at evidence of end organ damage, perform the urea and electrolytes, perform the urine routine to look for proteinuria, perform CBC, TSH, lipid profile, ECG to look for evidence of left ventricular hypertrophy, and offer cardiovascular risk assessment. Numerous online calculators are available which can help determine the cardiovascular risk scoring. Moving on to some special tests. So not every patient who has been diagnosed as having hypertension will require all these special tests. But you can offer them that in patients who develop hypertension at extremes of age, in patients whose evaluation reveals a clinical clue that the patient might have secondary hypertension, like a renal bruit, or if a patient has new onset hypertension or worsening hypertension in a previously controlled patient, or if the patient presents with resistant hypertension. In these cases, you may think about some special tests, which we will discuss in another video. Moving on to management, non-pharmacological management should be offered to all patients. You should advise weight loss in obese and overweight. It is said that approximately 1 kg reduction in body weight lowers the blood pressure by about zero point 0.5 to 2 millimeters of mercury. You should offer the patient DASH diet, which is diet rich in fruits and vegetables, low in sweets and red meats and sweetened beverages. Exercise, both aerobic exercise and isometric resistance exercises, have been shown to lower blood pressure. You should limit alcohol intake and consume a diet low in sodium intake with potassium supplementation. Pharmacological treatment. So, not everyone who has been diagnosed as having hypertension will require immediate pharmacological treatment. So, some thresholds of starting pharmacological treatment in patient with elevated blood pressure are as such. Let's say the out of office average measurement. That means home blood pressure measurement is more than 135 over 85. So he is a good candidate to initiate pharmacological treatment. Or if, let's say if the average office blood pressure measurement is more than 140 over 90, he is a good candidate for initiation of pharmacological treatment. And of course, let's say if someone has evidence of end organ damage, he is also a candidate for pharmacological treatment. You can start treatment at lower thresholds as well. Let's say if someone has a blood pressure of more than 130 over 80, but has established cardiovascular disease or diabetes or chronic kidney disease, or his 10-year cardiovascular risk is more than 10%, then they are also a candidate of initiation of pharmacological treatment. Some of the drugs, we'll be going into depth about the various drugs and the options in another video. But what has been said is multiple guidelines and meta-analysis show that the degree of reduction of blood pressure is more important than a choice of any individual agent. Some patients, they might have a compelling indication for a particular agent due to a comorbid condition. But some of the common agents are ACE inhibitors, ARBs, calcium channel blockers, thiazides, and combination if treatment goals are not met. Another brief overview about the treatment targets. So, treatment targets should be individualized for every patient. This should be documented in the patient's notes as well as verbally informed to the patient. So, some clinicians prefer a more aggressive threshold. Let's say the target threshold for blood pressure should be less than 130 over 80. But we can also take a less aggressive approach, especially in patients who have like labile blood pressure or postural hypertension or are experiencing side effects with the medication or elderly patient. It should be important that this treatment target should be documented in the patient notes and also be verbally informed to the patient. So that was a brief overview about hypertension, and we'll be going into depth in our later videos.